Hello and welcome to the Science of Skin podcast. My name is Dr. Ted Lain. I am a board-certified dermatologist practicing in Austin, Texas. And with me today is a really great friend of mine and a wonderful dermatologist, a leader in our field, a global dermatology expert, Dr. Todd Schlesinger. Dr. Schlesinger is the medical director of the Clinical Research Center of the Carolinas. He is a clinical assistant professor of dermatology at the George Washington University School of Medicine and Health Sciences. He's also either an assistant professor or a clinical instructor at multiple other College of Medicines, including University of Buffalo, Department of Dermatology, Medical University of South Carolina, and Edward Via College of Osteopathic Medicine. Dr. Schlesinger, I don't know how you have time to do all that, but it's so great to have you on the program. Thanks for coming on.
Thanks, Dr. Wayne. It's happy to be here. Speaking from the mouths of babes, to talk about a world expert here at in dermatology. So I'm very excited to be here with you. And this is my first time being on the Science of Skin podcast. So this is great.
Yes, we're super excited to have you. And of course, Todd is also on the board of advisors for the American Academy of Dermatology. So if you've heard his name, you hosted the Dialogues of Dermatology. I mean, Todd has done so much in dermatology that if you haven't heard his name, you've probably had your head in a hole somewhere. So
Board of Directors, Board of Directors, the Academy Board. Yes,
Board of Directors.
Yes.
Oh,
that's
sorry.
okay. No, that's yeah. So that would I better correct before I hear from the powers that be.
I don't want that to happen. All right. Well, one of the topics that Dr. Schlesinger speaks on internationally is treatment for non-melanoma skin cancer. Of course, Todd, you're a Mohs surgeon, which we rarely ever talk about, but you are a Mohs surgeon trained at Cleveland Clinic, right?
Yes. And to be totally honest, I did Mohs for about 22 years, and actually I kind of gave that up. I say I gave it up for Lent 1 year, but during the COVID time, right before COVID, I hired another Mohs surgeon in my practice, and I really turned over the majority of the practice to her after doing that for many years, only because my travel schedule didn't support the clinic time it required. So I wanted to make sure my patients were taken care of. So I sort of put that aside in my practice, and it's gotten replaced with a lot of other things that I do. So, but again, the experience that I have doing Mohs surgery for 22 years is invaluable, and I continue to do a lot of work in skin cancer and surgery every day. So,
Absolutely.
But yes, so yeah.
Well, I thought we would focus on one of these areas of expertise that you have, which is the treatment of non-melanoma skin cancer using Hedgehog inhibitors and PD-1 inhibitors, PD-L1 inhibitors as well. And so maybe, Todd, if you don't mind, we could jump first into the Hedgehog inhibitors, the vismodegib and sonidegib. And we could just kind of talk about what Hedgehog inhibitors do, like what they target, and when they're indicated, because I think most of us don't see humongous basal cells every day, but the more and more that we know about these drugs and the safety comes out and the clinical use is, we have more clinical use, I think we're going to feel more comfortable to pull the trigger on using them. So you have been a leader and innovator in this field for a long time. So maybe you could just walk us through that.
Yeah, so a great question. Yeah, so these molecules you mentioned, vismodegib, sonidegib, work on an embryonic pathway that's normally quiescent in basal cell carcinoma. Most basal cell carcinomas have mutations in some part of this pathway, not all. It's basically a system of a transmembrane pathway called patched. There's also a protein called smoothened, and through this pathway you get communication into the nucleus. And so again, normally it's quiescent. It's an embryonic pathway that normally stays quiet in the adult somatic situation. And when mutations occur along this pathway, you get overactivation of gene transcription through what's called the GLI1 pathway. And mutations can occur in different places along this pathway, typically in smoothened, sometimes in patched. Sometimes they can be suppressor mutations where you see a suppression of a gene that's supposed to be active, or it could be an activated mutation, the gene's supposed to be suppressed in there. So you could either have an overactivation of the GLI1 pathway, which increases transcription in the nucleus. And what happens there is if that pathway is active when it shouldn't be active, then you've got a cell that gets out of control. It differentiates quickly, divides too quickly, becomes unable to sort of control itself. As you know, basal cell carcinomas originate in the basal layer of the epidermis, probably in the interfollicular cells where they're coming from. And the basal cells, they really don't have those intercellular connections that keratinocytes do when they become keratinocytes. So basal cells tend to be juicy, ulcerated soft tumors that, as we know, can form what we classically know as the rodent ulcer. When they get larger, they kind of have an eat away appearance, and then get very large. And I think most people don't think about basal cell carcinoma as being that kind of dangerous tumor where it can get locally invasive and or metastatic even. That can happen. So, just think about that patched pathway. We call it the hedgehog pathway, which is what the whole sort of pathway. And these are hedgehog pathway inhibitors, or hedgehog inhibitors, or HHIs, how they're commonly referred to. And of course, we have got two of these that work very similarly on that pathway, but have important differences.
Yeah. Okay. So let's dive into the differences between the two. So Erivedge and Odomzo. Erivedge, of course, being vismodegib. Odomzo being sonidegib. My understanding, Todd, correct me if I'm wrong, but so Odomzo is the latest one for us to have available in our armamentarium. Erivedge was the first. Is that right?
That's true. Yeah,
Yeah.
Erivedge. I can't remember the date it was first approved, but it's
Okay.
been a good while. We've had that for probably over
Yeah.
10 years, maybe longer now.
Okay.
And then sonidegib was, I can't remember when it was approved. This is 2026. I think it came around maybe the end of before the decade turned over, around that time, if I can
Okay.
remember
So been out for a
accurately.
while for
A
sure,
while. They
right?
both have been around
Yeah.
for a while, and I think the key differences are, and I think clinically the number one people are going to think about is efficacy and safety, right?
Mm-hmm.
But that's underlined, but a few things to think about the two medications themselves. So I think the most important difference, I think, with these two medications is what we call the volume distribution, and the volume distribution has a lot to do with how the drug is distributed in the body. So if you think about the volume distribution of vismodegib being between 16 and 18 liters, and the volume of distribution for sonidegib being 9,000 liters, approximately just around 9,000 liters, it's a much more lipophilic molecule. So, if you think about that, it from what we can, understand just theoretically, it probably gets into far more areas of the body than a drug with a smaller volume of distribution. And then the way I talk about that to compare the two is that the volume and distribution of human blood or plasma is around 50 to 18 liters. So that's sort of, what you're thinking about. So if you think about something with an under 20 or under 40, it's probably staying mostly in the plasma, maybe a little bit outside, but a volume distribution of 9,000 is probably going everywhere in the body. And of course, our skin is made up of lipids, as we know how much lipid there is. So we're hoping that sonidegib as a medication with that volume distribution is getting into those lipids. But again, these are all theoretical differences that we see. So we talk about these a lot, but really, we know the difference of the volume distribution is there, but we don't really know how to directly connect that to the efficacy and safety of the medications. We just think about it.
And when you compare the two, Todd, I know there's no head to heads, but when you look at the complete and partial clearance data between the two, I believe that Odomzo it looks a little bit superior to Erivedge just from their separate trials.
Yeah, it's relatively similar. And again, you're totally right. We don't have head-to-head studies to compare the two. I would say in the clinical practice, they probably both work what I would call better than advertised. I've heard this term
Okay.
before. Scott Deinhardt loves to use that term as well. A good friend of mine. Basically, better than advertised. So when you put these drugs to practice in the clinic, you look at the numbers that you see in the labels, and they're kind of low, right? 6% complete clearance rate. 20, 30%, response, complete response rate, which means complete absence of tumor on biopsy. But most of your patients probably will respond if you can keep on the drugs long enough. The two trials were done very differently with different outcome measures. We could talk about that in more detail, but there's significant differences in how the data was reported between the two medications, which can make it very hard for clinicians to compare the two drugs directly, even if you're in your mind would like to compare the outcome measures of the two. It's hard to because they were both measured differently.
Okay, we should definitely talk about that. But Todd, I wanted to back up a little bit and talk about what these are indicated for. So vismodegib, metastatic or locally advanced basal cell, sonidegib, only locally advanced basal cell. Of course, we know that metastatic basal cell is very, very rare. But in your mind, Todd, what does locally advanced basal cell mean?
That is an existential question. The locally advanced term is a construct of pharma. Basically, these drugs have been, the Sun is not the original marketer of this medication, not the original developer of this medication. So I think when it first kind of came around, people were looking for something to say, to define what a, sort of more advanced basal cell carcinoma is, and we still don't have a clear definition. So when I think of locally advanced, I think of a tumor that is not amenable to surgery and or radiation, but mainly surgery, in such that the procedure itself would carry a risk of morbidity to the patient that might not be acceptable, right? So, you talk to a surgeon and they'll cut anything off, right? They'll cut our heads off if they
Yeah.
have to, right?
Yeah.
But the bottom line is that what we really want? Are the adverse effects of cutting your head off going to be appropriate? So when you think of a tumor that is not something that you say, hey, maybe we shouldn't be cutting on this right away, that's when I think of locally advanced. So you can define that further into a large tumor. It can be defined as tumor with high risk factors, such as perineural invasion, invasion of deeper structures, bone, cartilage, muscle, things like that. When basal cells get big, they can pretty much invade anything. It's just, usually it's local. Like you said, metastatic is rare, but locally advanced, it can eat into any tissue it really wants to. So that's what I think about there. And I also think about one other category, and that's multiple tumors. So you think about patients that walk in on a Monday morning, have got 7, 8, 9, 20, 30 basal cell carcinomas of different sizes, or maybe they're clustered in an area that makes it, I don't think we're going to spend the next 5 years cutting on this person, right? It's
Yeah.
another category to think of as multiple tumors.
Okay. Okay, great. Thank you. And these are, I don't know that we've mentioned it, but these are both oral drugs, right? These are pills that you take. These aren't infusions, much like the PD-1s are infusions. These are pills. And they're supposed to be taken daily, but from what I understand, Todd, decreasing frequency of dosing and or taking breaks is pretty darn common because of the adverse events, which muscle cramping, it sounds like, in lack of appetite or dysgeusia seem to be the top three.
Yeah, those are the most common things. Muscle cramps, weight loss, dysgeusia, as you'd mentioned, loss of taste, fatigue is up there as well. Those four are the main ones that patients will probably suffer from. And you mentioned a very important thing, which is alternate date dosing. So the vismodegib was studied in a study called the MIKIE study, which we participated in. It was a phase 2 study that was probably in the 15, 16, 17 timeframe, maybe a little earlier in the early 2000s. And that study was designed to look at just at that, because people were doing all kinds of different things with dosing. We still do, right? The whole point is, can we keep the patient on the medication? Because we know these drugs take several months to work. Fortunately, the beneficial effects, the efficacy usually precedes the development of adverse events. So, if you could get people on the medication and keep them on long enough to start seeing a benefit for their tumor, maybe they'll tolerate the adverse event more than they would like if they weren't getting a response. So out of that developed the MIKIE study, which was looked at 2 different dosing regimens of vismodegib. And the whole point was determine whether like an 8 or a 12-week break between dosing would, and I can't remember the exact categories, but they had 2 arms, and one had a shorter break, one had a longer break. And they ended up coming out relatively similar. The efficacy wasn't that much different if you gave the patient breaks. So if they maybe went on for 8 weeks and then took a 4-week break, or they went on for 12 weeks and took a 4-week break, they were pretty close. Like, I don't think even statistically significant, but the adverse events were better. So that's one thing that came out of that. And there's another study called the STEVIE study. The STEVIE study was a global large safety study for vismodegib, and that was a kind of concurring or around the same time. And the STEVIE study was all about adverse events. So what it told us is that if you've got adverse events early on with these medications, if you were able to stay on it, they would fade. So sometimes hair loss would get better over time. So those were important studies for us to understand what the short and long-term safety profiles are for these medications, so we can really, the goal would be to keep our patients on long enough, either get that complete response or a good partial response, or that we could maybe turn the patient from a non-surgical into a surgical candidate.
Mm-hmm. I was doing a little bit of research for today's episode, and there was a couple of papers that were talking about strategies to help prevent the adverse events, particularly the muscle spasms. And one was talking about taking calcium and CoQ10. And I know, Todd, you have talked about, you've told me about some other strategies as well to help limit that. So I think we benefit from the long time that these have been available for use, and many people kind of figuring out ways to help limit the muscle spasms in particular.
Yeah, so if you look at it, basically what you're kind of doing with these drugs is you think about this pathway that's, I think, a good way to think about it clinically, is this pathway is present all over the body, right? It's not just in basal cells, it's in the follicular stem cells of the hair follicles, it's in the GI system, it's in the tongue, it's in other parts of the body. So when you attack this pathway and slow it down, you're also affecting other parts of the body. So and that's why you end up with those adverse events that affect the GI system, muscle cramps. So you're kind of destabilizing mitochondria in the muscle, with muscle cramps. So that's really a mitochondrial destabilization. And so one thing that came out of that is, hey, what can we do nutritionally to support the muscle mitochondria so you don't get those cramps that you would normally get? And this can also happen, like, we both work out, right? So we know about anaerobic and aerobic muscle. When do you get muscle cramps? From lifting weights too much, right? It's from anaerobic metabolism of the muscle. So that's similar. You start to turn from burning oxygen to burning anaerobically, and that's also it can give you bursts of speed, but it's also extremely inefficient as a mechanism of burning energy. So you end up with those cramps and the lactic acid build up, and you get the muscle cramps. So out of that came L-carnitine, which was studied in small study, showed that it could help reduce the risk of adverse events for both drugs, really, and it's actually become quite popular when it's come into clinical practice. So I routinely recommend patients take, if they can tolerate, they don't have comorbidities, to take L-carnitine. I usually start them on in advance. So it's one thing we talked about. 2 to 4 weeks in advance, I'll recommend about 1,500 to 2,000 milligrams of liquid L-carnitine. It's available on Amazon, so it's quite widely available, inexpensive supplement. That's one thing I do, and I think that's really made a difference in the muscle cramp reduction for my patients, and be able to keep them on medications. It's almost one of the first things they start to get is muscle cramps after a couple months. Usually it starts to kick in. So that's really helped a lot. So one thing we can do is L-carnitine.
Okay, great. Well, if thank you so much for that, Todd. You're obviously such an expert. You've taken us through all the data, taken us through some tips on how to kind of combine both the Erivedge and the Odomzo with supplements like L-carnitine to help reduce the adverse events. Let's move on to the PD-1 inhibitors and PD-L1 inhibitors, which of course we're moving from the realm of basal cells to the realm of locally advanced and metastatic squamous cells. And so PD-1, programmed death 1, it's a protein receptor on T cells. And I think of that as like an immune checkpoint, right? And if we affect it, if we turn it off, it essentially just allows cancer cells to evade the immune system, because that's we need PD-1 for the immune system to recognize cancer and others. Is that how you think of it, Todd? Am I too basic?
No, that's totally a great way to think about it. That my best analogy, and I made this one up years ago, is the Starship Enterprise cloaking, right? So, cancer cells are tricky, right? They have figured out a way to hide themselves as basically being sense of self. So they express cell surface ligands that make the cancer cells that make T cells think they're fine. So this all comes from the tolerance mechanism that our body has when we're developing. There's a gland called the thymus gland that your T cells run through, and that teaches them what's good and what's bad. If the cells don't know what's good and what's bad, you have autoimmune disease like lupus, right? Same thing with cancer. Cancer cells figured out a way biologically to trick the immune system into thinking they're okay. Not always, right? We have different mechanisms. Sometimes they start to get inflammation, right? But they're tricked themselves, so they're cloaked. So when that mechanism is working, the enterprise is cloaked.
Yeah.
If you block that checkpoint, you suddenly reveal the enterprise, and it can be attacked by the Borg. So that's kind of what I think of the CD8 cytotoxic, CD8 positive T cells, or the Borg. They go in there, they attack the enterprise. So that's how it works. So it's sense of self, protection, block the checkpoint. So they're going, hey, I'm going to keep going, or I'm going to stop here and I'm going to attack. And that's basically what you're seeing. And so these receptors are on the surface of your T cells, PD-1, and they interact with PD-L1 and PD-L2 receptors that are actually on the surface of the cancer cells. And that's the mechanism you're talking about.
Okay, right. So PD-L1, the ligand attaches to PD-1 and that on T cells, and that decreases the proliferation of T cells, inhibits their killing ability, essentially switches off the immune response. It's interesting. PD-1 also plays an important role in autoimmunity, right? It prevents autoimmunity by suppressing overactive T cells. So there's other opportunities for us to focus on PD-1 aside from cancer, but we know that PD-1 is upregulated in tumors, and it's upregulated by UV exposure as well, right? Through pyrimidine
It's
dimers.
it's all over the by Tregs. This is extremely complicated.
Okay.
Pathway.
So I think we've gotten about as far as I'm able to go. So let's move on to what these PD-1 inhibitors are. So we've got cemiplimab or Libtayo, pembrolizumab, Keytruda, and nivolumab, Opdivo, and these are for squamous cell cancers. Actually, cemiplimab, Libtayo is also for basal cells, right? You can use those when those are resistant to Hedgehog inhibitors.
Yes, and it's approved. It's approved for both locally advanced and metastatic on both sides. And it's still that same. It's a very similar sort of indication statement. It's not amenable to curative surgery, curative radiation. So, and that leaves the judgment to the clinician of what that might mean.
Yeah.
So they're basically designed for primary therapy when surgery is not an option or radiation is not an option.
I can understand derms prescribing the Hedgehog inhibitors, oral drugs. We can deal with those AEs. But for these PD-1s, Todd, are you prescribing these yourself, or are you kind of doing this in partnership with an oncologist?
So I when I did the studies, we infused. So we did infuse in our clinic, and I have an infusion nurse and IV set up, and we did all of it ourselves, and we managed every side effect you can possibly think of with these medications, right? So I think it's not something that derms can't do. I think derms can, and some derms do it. Okay. I think the main barrier here is more logistics. So, of course, not every derm is going to be comfortable managing the adverse events that come from checkpoint inhibitors, right? Immuno-oncology drugs. And these are not medications you use in isolation. You do this as a team, a multidisciplinary team involving many different players. But that doesn't mean the derm can't be the captain of the care team in this case in monitoring this. The thing is, the infusion setup requires certain things to be in the office. You need a setup, infusion hood, all these different things to do the infusion. That's more of a logistical headache. It's a buy and bill headache, and it could also be, a volume. Are you doing enough infusions to make it worthwhile? If derm that's doing infusions probably should be doing multiple types of different things in their clinic, and maybe be an infusion center of excellence. Is every derm going to do it? Absolutely not. Or most? No. Maybe a few.
Okay, so most derms then, we see a locally advanced squamous cell, we think, oh boy, worried about this one. Looks like there might be metastasis, and or it's so locally advanced, I don't think that the Mohs surgeon would touch this, and they'll probably send for imaging and probably get the oncologist involved anyway. Now we understand, derms may not be prescribing these drugs, but certainly we need to be aware of these drugs. And now hopefully everyone understands how these PD-1 inhibitors work and what the target is. And again, PD-1 is upregulated on tumors and by UV exposure, which makes a lot of sense. Todd, thank you so much for that. I think that there's a couple of drugs that are interesting in development that you and I have spoken about previously. Especially for basal cell cancers, where we're not talking about locally advanced basal cells, but just run-of-the-mill nodular superficial basal cells that we see a million times a day. And we've got these startup companies that are focusing on intralesional therapies for especially nodular basal cells, which I think we both agree it's sorely needed, right? We surgerize these way too much, especially for relatively indolent cancers. And if there are a way for us to eradicate them without leaving a scar or making it easier on the patient, I'm all for it. One of these is Verrica. They're moving into their phase 3 with their intralesional therapy. And Todd, you did the phase 2, right?
I didn't do the phase 2. I looked at it very carefully. I work with Verrica a lot, but I didn't do the phase 2 only because my site is small and the requirements for that study were just more than I was excited about it. But there was intensive monitoring requirements that were maybe not part of the phase 3 that were part of phase 2. That my staff were like, okay, we got to monitor the blood pressure, every hour or whatever. There's some things so we didn't do it, but I followed it very closely.
Yeah. So we were part of the phase 2 program, and very interesting results. I think our results showed what phase 2 showed. I think we mirrored on my site what the overall results were, which were positive. Certainly, I'm excited and enthusiastic for this drug to move into phase 3, and looking forward to seeing this at a greater patient population. But just super excited about the idea of using this on, both the trunk and the face, not very close to the eyes or anything like that, but huge opportunity there. And then there's another one, Highlight, right, which is probably earlier stage at this point, but also an intralesional therapy for basal cells. And so there are lots of work going on now to help us with these, as I mentioned, kind of indolent, annoying skin cancers that probably won't kill you, but we got to get rid of them. Otherwise, they can turn into that rodent ulcer appearance and lead to some comorbidities. But besides those two, I think Iviva might be another one. Todd, is that right?
Yeah,
Yeah.
Iviva's another one. There's also a couple of, well, first one I mentioned, the basal cell red light PDT study
Oh yeah.
that came out in the fall. So that's a big one. Just be aware,
Thank you.
superficial basal cells probably headed toward approval.
Mm-hmm.
And then you've got, it's at the FDA now. And then you've got the Feldan and FIO. So PHIO and Feldan. Those are other two companies. One's a shuttle, basically the way to shuttle proteins into the cells is one interesting thing. And so I think there's a ton of even things you haven't mentioned yet that are coming. Not only delivery systems, but new molecules. So yeah, I think the America drug's very exciting. Oncolytic protein. Hopefully it's going to be very specific to these tumors. I think the big picture about all these new medications is going to be where they're going to fit. So are these going to be neoadjuvant therapies given before surgery? Are they going to be primary given instead of surgery? Are they going to be, perioperative before and after, adjuvant after? So I think there's important things to talk about there. And also in PD-1, there's the PD-L1 pathway, the other side of the world as well, when you're on the tumor cell. So it's just, I would say that I agree with you 100% that this field is exploding right now. There's so much going on that's sometimes hard to keep up with.
Yeah. Yeah. I mean, you can imagine if we could do neoadjuvant to shrink the tumor enough to even be amenable to like a punch removal or something like that, like make it so small to make it just super easy in the office. I think that's where we will be in the next, hopefully, certainly 5 years. And by 10 years, we'll probably have multiple
The,
competitors out
the
there.
big
So
clinical thing, Teddy, is to think
yeah.
about is what the efficacy is. So there's an efficacy range
Yeah.
that you think about, I think, for neoadjuvant, and an efficacy range you think about for primary therapy. And I think those are very different. So if a drug has a 30, 40, 50% efficacy, complete response rate, that's probably neoadjuvant. If you get higher, when we look at PDT for AK and then PDT for basal, it's in the 60s, and combined clinical response rate for pathin and in clinicals in the 60% range. It's getting there. But really, I think we need to be up in the 80s to 90, 95% to really be able to call these primary therapies. Because remember, these patients don't want to come back in 10 years and have that basal cell coming back. We don't want to be in the ED and C range. We want to be higher. So
Mm-hmm.
we got to have lofty goals. We got to aim high for this stuff.
No, but Todd, thank you for bringing that up. It's a great point in that, we're definitely pushing the edge of science right now, but complete response rates in the 50 to 60%, composite where the clinical appearance as well as the histopathologic verification are the same. It's difficult. It's difficult in any trial. Anytime you have a composite endpoint, no matter what you're talking about, it's the most difficult to do. And we need that for basal cell in particular. And like you said, I think derms would probably only be comfortable this as a primary therapeutic option if we're looking at 80-90+%. So thank you, great point. Otherwise, neoadjuvant though is worth it. It could be something that especially for highly cosmetic areas, for example, this could play a huge role. So not to
It's
diss
probably the
on.
way where most of us are doing it. So I
Yeah.
want to get that point out there because that's a very important point you brought up on neoadjuvant. It's probably the way most of these drugs are being prescribed now. And it's the current future, which means it's the now before we have the data, because none of them are approved for neoadjuvant, although it's coming. But adjuvant therapy was approved for Smoothened, got the label change and update that in the fall, right? But neoadjuvant, I would argue most of my cases that I'm giving Hedgehog pathway inhibitors and even PD-1, PD-L1s is going to be neoadjuvant,
Okay.
unless it's to the point where you don't have any other options, and then it's primary.
Okay. So just to define some terms, neoadjuvant meaning you give it before you do a surgery. Adjuvant is usually after a procedure, for example.
Yeah, and perioperative is both.
Yeah.
And there's data, great data showing, and even in melanoma world, because you mentioned nivolumab, it's really more melanoma drug. But in reality, there's great data showing, hey, the key thing is, do we want to activate the immune system before surgery, or do you want to do it after? And I'll argue, and I think a lot of people argue, you want to activate the immune system and start killing off the tumor, get those CD8 cytotoxic T cells active before you excise, and that can help to reduce the risk of recurrence later.
Brilliant.
So if you take that out, if you remove the tumor with all its associated tumor infiltrating lymphocytes surrounding it, and then you try to go and raise immunotherapy around that, what do you got left, right? Yeah. So you want to activate the cells that are there and get them going, get the tumor shrunk down to a, and then remove it, and then maybe hit it again after to get the best outcome.
For those who are listening to the podcast and not watching on YouTube, you are missing a great show behind Dr. Schlesinger. His dog Grady is having the best nap in the world. I think we all wish we had.
Anytime I'm talking, he's usually doing that. Most people are.
Todd, thank you so much, man. This has flown by. I learned every time we talk about this, I learned something from you. You truly are an expert, and we really appreciate it because we need derms who are experts in this field. It's rapidly changing. And I think I would just urge everybody to make sure, especially for the hedgehog inhibitors, you are aware of them. You understand that you can prescribe them. And I think Todd has helped me tremendously. I called the red line and he picked up when I had a patient and he helped me through it. And please consider prescribing these on your own because I think it can be done. And then just knowing about PD-1 is important and utilizing the relationship with your local oncologist. And then keeping an eye on the pipeline, as I mentioned. Todd is very much involved in that because I think it's going to change the way we treat specifically superficial and nodular basal cell, which again, I believe it's huge for patients. So Dr. Schlesinger, this was great. Thank you again so much. Appreciate it.
Thank you as well.
Yeah. So this is another episode of Science of Skin podcast. Thank you so much for listening. If you liked it, give us a 5-star rating, please. Subscribe. Of course, we found that our podcast growth really occurs through word of mouth. So please refer us to a colleague. I'm sure they'll learn something from our great expert guests like Dr. Schlesinger. Thanks so much for listening.